First of all, I'd like to appreciate the organizing committee and Dr. Kanamori for inviting me to this honorable symposium. And I am a pediatric surgeon, and I'd like to talk today about a very specific situation, who the patient who needs surgery just after birth and with very severe congenital diseases, and how to control the intestinal microbiota in such patients. This slide shows the hospital. This is the largest children's hospital in Japan, National Center for Child Health and Development. I'm afraid you all are not familiar with the severe congenital anomalies with intestinal failures. Shown in this slide, this is a meconium peritonitis, who had the intestinal perforation before birth. And this is a severe type of the omphalocele, the defect of the abdominal wall, maybe just after birth. So it's very difficult for this patient with many times the short bowel syndrome and the intestinal motility disorder. And in these cases, we need neonatal surgery. And the second, antibiotics administration is mandatory, and often they restricted the oral feeding. And in this age, the immaturity of intestinal function, and also they have a immaturity of immune function. So these patients have a primary or secondary intestinal dilatation, and that results in intestinal dysmotility and bacterial overgrowth. And these affected babies acquire quite abnormal intestinal microbiota in their early infantile life. We examined the 11 patients who have been admitted more than 1 year just after birth in 1990s, about 20 years ago. Shown in this slide that the Bacteroides and Bifidobacterium, famous predominant anaerobic bacteria, decreased in these patients, and also the Staphylococcus, Pseudomonas, and the Candida, considering the pathogenic bacteria, increases dramatically. So in these patients, anaerobic bacteria decreased prominently, and aerobic and pathogenic bacteria increased in the intestine. This is a quite abnormal intestinal flora. And also the short-chain fatty acid in the feces decreased dramatically comparing to the control of the neonatal ages, normal neonates or the normal children. So abnormal bacterial floras resulted in the abnormal metabolism of the bacteria, and that finally decreased the short-chain fatty acid in the fetus. And in 1990s, we experienced a very miserable cases. For example, this slide shows the giant immature teratoma of upper pharynx. They couldn't breathe at all after birth, and tracheotomy was immediately done. And also, the patient could not feed any milk. And in this patient, 12 days old, MRSA, methicillin-resistant Staphylococcus aureus, was detected in pharynx, and 14 days old, MRSA detected in stool. And after all, the 15 days of old, intestinal perforation occurs due to the MRSA enterocolitis. And in this patient, the intestinal microbiota was quite abnormal, and the MRSA was as high as 8.53 or the 5.92 in exponential values. And this situation is life-threatening in the intestinal microbiota. And after all, the patient died about 100 days old. So we considered that how to prevent these miserable situations in our patients. And in 1997, we developed novel symbiotic therapies. That is two kinds of probiotics, Bifidobacterium breve Yakult and Lactobacillus casei rota. And as prebiotic, we adopted the galacto-oligosaccharide. This is a commercial base of the product Oligomate that was offered from the Yakult Honsha. And this symbiotic therapy is to treat the abnormal intestinal microbiota by the probiotics. So we named this therapy as a therapeutic use of symbiotics. And these two kinds of probiotics have similar characters, specific characters. First, this is a safe, relatively safe bacteria and resistant for gastric juice, and it contains high numbers of bacteria. And also, it's possible to count numbers of probiotics bacteria using a monoclonal antibody to the two kinds of probiotics bacteria. And this is the first symbiotics case. The patient suffered from the gastroschisis. This is also the defect of the abdominal wall. And just after birth, a large population of intestine was seen. And we resected the vast majority of the intestine. And she suffered from the short bowel syndrome. At 4 years old, the patient's intestinal microbiota was analyzed by the culture method, and it was very abnormal, just containing the candida, and no bacteria resided in the intestine. This is we named the high-risk phase. And just after treatment, starting our symbiotic treatment, the probiotic bacteria resided very well, but still the candida content is very high. This is the probiotic dominant controlling phase we named. And actually, more than 1 year's treatment, the patient intestinal microbiota changed, very similar to the normal one. The bifidobacterium is very high, highly detected, and the candida was disappeared in the intestine. This is the anaerobic dominant phase I named. And first, this successful case was reported in 2001 in Digestive Diseases and Sciences. And intestinal motility restored in this patient, along with the improvement of intestinal microbiota, and maybe this effect prevents the bacterial overgrowth in the intestine. And the clinical course was very impressive. Before starting treatment, the symbiotic therapies, body weight did not increase at all, but just after starting our symbiotic therapies, body weight increased dramatically, and the patient never experienced the severe enterocolitis. So after the successful case of our symbiotic therapies, we applied 7 another patients by our therapeutic symbiotic therapies, more than 1 year. And the result is very favorable, and colonization resistance. That means the aerobes to anaerobes ratios recovered by symbiotic therapies from the 46.9% to the 5.73%. This means the dramatic increase of the anaerobic bacteria in the patient's intestine. And short-chain fatty acid also increased more than double before and after the symbiotic therapies. This means a improvement of intestinal microbiota results in the normal metabolic activity of the bacteria in the intestine, and that resulted in the prominent increase of the short-chain fatty acid in the intestine. Clinically, the improvement was also seen. The body weight gain increased after the therapy, and the pre-albumin level increased statistically after the treatment of our symbiotic therapies. And we examined so many our patients' intestinal microbiota, and I have noticed that the intestinal microbiota in our patient is classified into the 5 phases. One phase is the phase 1A, we named phase 1A. This phase is the commensal aerobic bacteria dominant phase. And this is the early infant phase and unstable. And the second one is a very specific phase, phase 1B. This is the pathogenic microorganisms dominant phase, and it has a very high risk for the intestinal infection. And we usually never experience these phases, but in our patients often see such an abnormal phase 1B phases. And phase 1C phase is very specific, and I cannot define the significance, but lactobacillus dominant phase. In short bowel patient, we sometimes meet this specific phase, and still I don't know the significance of this phase, the lactobacillus most dominant phase. And phase 2 means the probiotics dominant phase. And just after started our symbiotic therapies, the patient often shows this phase of intestinal microbiota, and this is considered to be a controlled phase of the patients. And lastly, the phase 3A means the commensal anaerobic dominant phases. This is very similar to the normal intestinal flora, and we call this as a stable phase. So we just classified these 5 phases of the intestinal microbiota to specify our patient state. And so I propose this classification is useful for defining each patient's intestinal microbiota state. And this shows the transient lactobacillus most dominant phases. 1-year-old boy with refractory enterocolitis. The patient's exact etiology of the enterocolitis was not clear, but I suppose that the patient had a natural killer cell deficiency, and these immunocompromised hosts, very refractory enterocolitis was seen. And before treatment, the patient had only the aerobic bacteria, and there was no anaerobic bacteria. And this we call this phase as a phase 1A, aerobic bacteria dominant phase. And after starting our symbiotic therapies, lactobacillus was most dominant bacteria in this period, and we call this phase as a phase 1C. But I don't know the exact meaning of the lactobacillus most dominant intestinal microbiota. And long-term therapies, finally the Bacteroides and the Bifidobacterium is most dominant, and we call this phase as a phase 3A. And after all, we applied our therapeutic symbiotic therapy to the 7 short bowel patients. And this slide shows the changes of the microbiota in the patients. First, before treatment, the intestinal microbiota of 7 patients had very few anaerobic bacteria and very high levels of pathogenic microorganisms. So, before treatment, the patients all have the phase of 1A or 1B, not so stable intestinal microbiotas. And just after treatment, so many probiotics resided in the intestine, and this phase we call the phase 2, were controlled by the probiotics. And after 1 year's treatment, all the patients acquire the bacteroides or the bifidobacteriums of their own species, not the probiotics bacteria. And this phase is very stable, and we call this is the phase 3A, intestinal microbiota. So the effect of therapeutic use of symbiotics result just after starting our symbiotic therapies, intestinal microbiota changes from the phase 1A or 1A to the phase 2 probiotic dominant flora. And lastly, we can acquire, the patient acquire the phase 3A, that's very similar to the normal floras. And in some patients, just after starting our symbiotic therapies, they acquire the phase 1C, lactobacillus dominant phases. And after all, through the phase 2, they acquire the phase 3A, similar to the normal floras. And these intestinal microbiota changes results also the intestinal function improving. So intestinal microbiota changes is corresponding completely to the intestinal function. And after we succeeded to treat the abnormal intestinal microbiota by our novel symbiotic therapies, 2004, we started more new symbiotic therapies that I call the early use of prophylactic use of symbiotics to prevent the acquired abnormal intestinal microbiota in the intestine. And the use of probiotics is the same as the therapeutic use of symbiotics. And as prebiotic, we adopted the mother's milk that contains so much oligosaccharides and very small babies. It's a bit difficult to use the direct oligosaccharides, so we adopted the mother's milk as a prebiotic. I have shown 3 cases of the prophylactic use of symbiotics. First case is the meconium peritonitis. That means the intestinal perforation occurred in fetal life, and the short bowel, small intestine, was as long as 85 centimeters long. And in this patient, first, the intestinal microbiota shows the phase 1A. There's no bacteria detected. But at the 3 months of age, probiotics became dominant, and we call this phase as a phase 2, probiotics dominant phase. And after all, 1 year old, the patient acquired the bacteroides and the bifidobacterium species, and this phase is very stable and similar to the normal ones, and we call this phase as a phase 3A. And corresponding to the improvement of the intestinal microbiotas, the patient's clinical course was very favorable and satisfactory, and we only used the intravenous hyperalimentation only 4 to 5 months after birth, and the patient discharged after 6 months after birth, and the clinical course was very satisfactory in spite of the very severe diseases. Second case is also the suffering from the meconium peritonitis, and the patient showed a hydroxyphytalis, very severe edema in the fetal life, and this means a very severe type of meconium peritonitis. And in the past time, we couldn't save his patient without any treatment. So the patient also had a short bowels. Small intestine was as long as 85 centimeters long. And in this case, also the first intestinal microbiota shows the phase 1A, but just after 1 month, the probiotic dominant microbiota was acquired in this patient. This is called phase 2. And 3 months of age, the patient acquired the bifidobacteria and the bifidobacterium. This is an anaerobic dominant phase, and also the very stable case. And in this case, MRSA and Pseudomonas and Candida was not detected at all, or the very small numbers. So this prophylactic therapies well controlled the overgrowth of the pathogenic bacteria. And the clinical course of this patient was also very favorable when the patient was discharged 40 days after birth, and the body weight gain was very good. And in these patients, abdominal rentgenograms showed that intestinal peristalsis was well maintained by our therapies, and abnormal dilatation never seen in our patients. So these effects will prevent the bacterial overgrowth in the intestine, and this reflects the well clinical course. The third case is also the meconium peritonitis, and the patient's small intestine was as short as 35 centimeters long. This is the extremely short bowels, and this is very difficult to treat in the past. But in our patient, the dynamic change of intestinal microbiota shows the phase 2 to phase 1C, and finally the phase 3A. This intestinal microbiota change resulted in clinical course in this patient. And we hypothesized that this favorable effect was attained by the following mechanisms. In normal infants, 80 to 85% of nutrient was absorbed in the small intestine, and 15 to 20% of energy was absorbed in the large intestine. But in short bowel patients with no control of intestinal microbiotas, nutrient absorption in small intestine decreased dramatically, and also the energy absorption in large intestine decreased. But when the intestinal microbiota is well controlled by symbiotic therapies, maximum activation of small intestine nerve function increases the nutrient absorption in small intestine, and also the energy absorption in large intestine restores. So finally, the very favorable clinical effect was attained by our symbiotic therapies. In prophylactic use of symbiotics, phase 1B was completely suppressed by our symbiotic therapy, and early induction of phase 2 and phase 3A was attained in intestinal microbiota, and this also results the improvement of intestinal function. And recently, the bacterial genetic analysis in intestinal bacteria was obtained, and so we checked the long-term effect of our symbiotic therapies in 7 patients with therapeutic use, and another group is 7 patients with prophylactic use of symbiotics. And seen from the serum level, the therapeutic use of symbiotics group show the Firmicutes dominant types, and this is similar to the control, but prophylactic use of symbiotics show the actinobacteria dominant phase, and this is not similar to the control. So, seen from the serum level, therapeutic symbiotics group show the favorable intestinal microbiota. But seen from the genus levels, therapeutic symbiotics groups show the quite abnormal intestinal flora. They show the loss of diversity and the distribution discrepancy comparing to the normal control. So in these patients, clinically the patient state improved, but the intestinal microbiota are completely different from those of normal children. And for the groups of the prophylactic symbiotics, the patient maintained the diversity well, and the distribution similarity attained comparing to the normal flora. So clinically satisfactory, but this phenotype is intimately seen. Still, the intestinal microbiota is not similar or the same to the control, and from these data, we think the more effective symbiotic or the probiotic therapy is needed in our patients. So in the future, we should how the new treatment should be developed in the futures, and the first possibility is a fecal microbiota transplantation. This is easier to apply, but with many difficulties for the pediatric patient, because how to adjust the age and how to prevent the virulent viral contamination, and the proper bacterial number is not known at all. So the more novel ideas for control of the intestinal microbiota is the selective microbiota transplantation, SMT. In recent report from Japan, for example, there are about 70 kinds of Clostridium bacterial cocktail will induce the regulatory T cell in the large intestine. So this proper cocktail of the bacteria might be very efficient in the controlling our patient. But this is more suitable, I think, but it's more complicated and difficult to plan. So it will take a bit more time to develop a new selective microbiota transplantation. This is the last slide of acknowledgement. I'd like to show a great thanks to these microbiotas. Thank you very much for your attention.